Good day, my name is Dr. Emma Scott and I'm an assistant professor of medicine. I'm the director of the Multiple Myeloma and Amyloidosis Center at the Knight Cancer Institute at Oregon Health Sciences University in Portland, Oregon. I'm here today at the ASH meeting and am reporting on the results of our phase 1 study of hydroxychloroquine with infusional cyclophosphamide, health dexamethasone and rapamycin in patients with relapsed or refractory multiple myeloma. The rationale and background of the study stems from the hypothesis that one can add in certain medications to enhance the sensitivity of backbone chemotherapy and delay the onset of resistance in patients with relapsed refractory multiple myeloma. So we have used cyclophosphamide and dexamethasone as an infusion, a continuous infusion, in a way that can be related back to hyper-CVAD. So it's almost like a less intense hyper-CVAD with just cyclophosphamide and dexamethasone, to be used in cases where you want to achieve cytoreduction as a bridge to something else, not using proteasome inhibitors or immunomodulatory agents. However, as we all know, relapsed refractory multiple myeloma patients develop resistance very quickly. Rapamycin is an mTOR inhibitor. The mTOR pathway has been extensively investigated in multiple myeloma and appears to be active in cell lines and patient samples in the lab. However, has been disappointing in clinical trials to date. And one of the mechanisms we believe for that is potentially an interaction with the autophagy pathway. And mTOR inhibitors greatly increase autophagy, which we believe then acts as an escape mechanism whereby proteins are degraded in the autophagic vesicle, and when the toxic stress to the cells, in this case cyclophosphamide and dexamethasone, are relieved from the cell, the proteins remain in the cells and become resistant. And so inhibiting autophagy with hydroxychloroquine is being used as a mechanism to overcome the resistance that we have seen historically with mTOR inhibitors and also with alkylating agents. So the main question in this study, it's a phase 1, is really to address what is the maximum tolerated dose of hydroxychloroquine in this population of patients when we use it in conjunction with a standard backbone therapy. And that was the main primary objective. We also had some correlative endpoints to evaluate whether it would be possible to identify levels of autophagy and mTOR activation in vivo in patients while they're on treatment. The eligibility criteria for this study were patients with relapsed or refractory multiple myeloma who had had at least one prior therapy, but they had to have had lenalidomide as well as bortezomib. Patients could not have had prior toxicities related to rapamycin or hydroxychloroquine, and they were not allowed to have a history of glaucoma or retinal disease due to the long-term effects of hydroxychloroquine on the retina. So those are the main criteria. So this is a straightforward phase 1 dose escalation study enrolling patients in cohorts of 3. There are 4 different dose levels of hydroxychloroquine ranging from 200 milligrams to 1,200 milligrams daily. Each cohort enrolls 3 patients until a DLT is encountered, and if a DLT is encountered, then the cohort is expanded to 6. So we were able to enroll a total of 16 patients thus far, and we expect to need to enroll another 2, so to a total of 18 patients. We've had 2 dose-limiting toxicities seen in the highest dose cohort of hydroxychloroquine 1,200 milligrams. And those dose-limiting toxicities were a grade 4 thrombocytopenia that did not resolve to grade 2 or less by day 1 of cycle 2. The second dose-limiting toxicity was a grade 3 diarrhea that also did not resolve to a lower grade by the time we started cycle 2. And gastrointestinal adverse events are expected with hydroxychloroquine, and these have been dose limiting in other cancer studies using this drug at higher doses. So hematologic toxicity was not higher than what we would expect with infusional cyclophosphamide, and other toxicities such as electrolyte abnormalities and things like that were also within the expected range. We did see 2 patients develop line infections, so neutropenic patients who developed staph-related line infections. One of those patients was the thrombocytopenic patient who came off study for the DLT. Overall, we did not see a very high number of neutropenia, and we did use pegfilgrastim 24 to 48 hours after each infusion of cyclophosphamide. Our conclusion is that this is a well-tolerated backbone regimen. Hydroxychloroquine at an 800 milligram dose level is well tolerated, and this level has been used in other cancer studies to achieve serum levels that are known to treat cancer. We have also done serial pharmacokinetic and pharmacodynamic assessments and have been successful in examining bone marrow biopsies on patients at 3 different time points, noting an overall increase in the accumulation of autophagic vesicles with treatment, indicating that there is some inhibition of autophagy occurring, as well as assessing the mTOR pathway using Western blots and immunohistochemistry. So my conclusion is that it's a well-tolerated regimen. We have some indication of preliminary efficacy, but the main conclusion is that it's well tolerated and that we're able to evaluate in vivo the levels of autophagy and mTOR activation and inhibition in these patients.